Popular culture has trained you to picture a coma incorrectly. The movie version looks like sleep. The patient lies still, eyes closed, peaceful, and then, after some emotional sentence spoken at the bedside, their eyes flutter open and they ask what year it is. Almost none of that is accurate. A coma is not a deep sleep. It is not peaceful in any neurological sense, and it almost never ends with a sudden, dramatic awakening. A coma is a specific, measurable disruption of the systems in your brain responsible for producing consciousness at all. Let's go through it properly. Consciousness has two components that need to work together. The first is arousal, the basic on switch, the difference between an awake brain and a sleeping or anesthetized one. The second is awareness, the actual content of consciousness. Thoughts, perception, the experience of anything at all. You need both at once for what we'd normally call being conscious. A coma happens when arousal itself is severely damaged, not simply cycling down on a normal schedule the way it does every night. The structure responsible for arousal is a small network deep in the brainstem called the reticular activating system, and it essentially acts as the power supply for the entire waking brain. Damage that network, however intact the rest of the brain might be, and the system it powers has no way to switch on. This is why the two most common causes of coma are mechanically so different. The first is diffuse damage to the brain's hemispheres themselves, from a severe traumatic injury, prolonged oxygen deprivation after cardiac arrest, or a metabolic crisis flooding the brain with toxins. Here, the arousal system may be intact, but there isn't enough functioning tissue left to generate coherent, conscious content. The second cause is direct damage to the brainstem itself, from a stroke, a tumor, or swelling that presses the brainstem against the base of the skull. Here, the cortex above might be almost entirely undamaged, but the switch that turns it on has been destroyed. Two completely different injuries, converging on the exact same external presentation: unconsciousness. So, what does a comatose brain actually look like from the bedside? Not like the movies. Comatose patients frequently retain primitive brainstem reflexes, even while entirely unresponsive. Their eyes might open spontaneously, without any tracking or recognition, a phenomenon that unsettles families precisely because it looks almost, but not quite, like waking up. There is no purposeful movement, no response to commands, no reaction to pain that suggests an attempt to withdraw from it, rather than a pure reflex. Doctors quantify all of this using the Glasgow Coma Scale, developed in 1974, which scores eye-opening, verbal response, and motor response from 3, the deepest unresponsive state, to 15, fully alert. A score of 8 or below generally defines coma. Now to the question almost everyone actually wants answered. Is anyone in there? For most patients in a true coma, the evidence-based answer is no, not in any way we can currently detect. But this gets complicated fast because coma is frequently confused with a related but distinct condition, the vegetative state, now called unresponsive wakefulness syndrome. A patient here has regained some arousal. Their eyes open, they may even have sleep-wake cycles again. But awareness, the actual content of consciousness, remains absent as far as any behavioral test can determine. This is where a landmark, genuinely unsettling study enters the picture. In 2006, neuroscientist Adrian Owen and colleagues published a study in the journal Science involving a 23-year-old woman diagnosed using every standard clinical test as vegetative following a severe accident. She showed no outward signs of awareness whatsoever. Owen's team placed her in an fMRI scanner and asked her to imagine playing tennis, then to imagine walking through the rooms of her house. In healthy subjects, these two instructions reliably activate two distinct, well-mapped brain regions. The unresponsive patient's brain activated the exact same two regions at the exact same times, indistinguishable from healthy volunteers. She could not move a finger to communicate, but somewhere inside a brain every bedside test had written off, something was following spoken instructions. Follow-up research has estimated that somewhere between 15 and 20% of patients diagnosed as vegetative using standard bedside criteria may retain this kind of covert awareness, detectable only through neuroimaging, never through any test relying on the patient producing an outward, observable response. This isn't evidence that most vegetative patients are secretly fully conscious. It's evidence that our standard methods for detecting consciousness can fail when the outgoing wiring needed to demonstrate it is damaged, even if the thinking itself survived. A true coma, though, appears to be different, and the distinction matters. Coma involves a much more severe disruption of arousal itself, rather than preserved arousal paired with damaged awareness. Studies using similar imaging techniques have generally found little to no evidence of this kind of covert command-following activity in patients meeting strict criteria for coma specifically. The weight of current evidence suggests true coma, unlike vegetative state, does not typically involve a hidden, aware mind trapped behind unresponsive eyes. The lights, in the most literal sense, appear to actually be off. That said, hearing occupies an unusual position, even in some deeply unconscious patients, which is part of why the advice to speak to unconscious patients isn't purely sentimental. Auditory pathways involve numerous redundant relay points below the level of full cortical processing, and studies have found that many comatose and vegetative patients continue registering sound at a subcortical level, even with no evidence of higher comprehension or memory attached to it. Given that uncertainty, and given the essentially zero cost of the alternative, most clinicians recommend speaking normally around unconscious patients, regardless. The path out of a coma also bears almost no resemblance to the cinematic version. Recovery is typically a gradual, often frustratingly slow reemergence through graded clinical stages, sometimes through the vegetative state as an intermediate stop, then into a minimally conscious state, where awareness is present but inconsistent. Then, if recovery continues, into fuller consciousness, often accompanied by significant confusion and a period where the patient may be awake and communicative, but not yet forming reliable new memories. There is generally no single dramatic moment of return, just a slow, uneven climb through distinct medical stages. Prognosis depends heavily on the underlying cause. Comas from traumatic injury generally carry better recovery odds than those from prolonged oxygen deprivation after cardiac arrest. Duration matters, but is frequently overstated. A longer coma correlates with worse outcomes, largely because it indicates more extensive damage in the first place, not because duration itself is independently harmful. There are well-documented cases of meaningful recovery after comas lasting weeks or longer. Modern neurology has become notably more cautious about issuing confident, early predictions of permanent unconsciousness, precisely because cases like Owen's have repeatedly shown our tools for detecting what's happening inside an unresponsive brain remain behind our tools for keeping that brain alive in the first place.